Delayed puberty is defined by the absence of secondary sexual characteristics at a chronological age exceeding 2.5 standard deviations above the population mean. In a clinical setting, this definition establishes a statistical threshold for diagnosing delayed puberty. It means that if a patient has not begun developing secondary sexual characteristics, such as breast development in girls or testicular enlargement in boys, by an age that is significantly older than what is typical for 99% of the population, they meet the criteria for delayed puberty. Using the 2.5 standard deviations cutoff helps distinguish between a constitutional delay of growth and puberty, which is a normal variation, and potential underlying endocrine or pathological conditions that require further investigation. Now, why 2.5 standard deviations matter? In a normal distribution, most of the population falls within 3 standard deviations of the mean. Being 2.5 standard deviations away from the average puts a patient in the extreme tail ends of the distribution, meaning they are statistically very rare compared to the general population. That age is typically 14 in boys and 13 in girls. Furthermore, because a critical body weight threshold is required to trigger the initiation of puberty, the timing of pubertal onset is modulated by ancillary factors, including nutritional status and the presence of chronic systemic disease. The causes of delayed puberty can be divided into 3 types: constitutional delay, hypogonadotropic hypogonadism, and hypergonadotropic hypogonadism. Constitutional delay of growth and puberty is the most common cause, representing a functional, benign variation where the hypothalamic-pituitary-gonadal or HPG axis is intact but activated later than average. Hypogonadotropic hypogonadism is characterized by low levels of gonadotropins and sex steroids, typically resulting from a failure in the hypothalamus or pituitary gland to initiate the pubertal signal. In hypergonadotropic hypogonadism, the primary defect resides in the gonads themselves. Despite high levels of gonadotropins, as the body attempts to stimulate the gonads are unable to produce adequate sex steroids. In cases of constitutional delay, skeletal maturity, as assessed via radiographical evaluation of the wrist and hand epiphyses, is characteristically delayed relative to the patient's chronological age. This occurs because sex steroids are essential for fusion of the epiphyses. Hypogonadotropic hypogonadism may be due to structural hypothalamic or pituitary disease, functional gonadotrophin deficiency, or isolated gonadotrophin deficiency. Structural hypothalamic or pituitary disease causes hypogonadotropic hypogonadism because it directly damages the physical machinery required to produce and secrete the hormones that regulate the gonads. Functional gonadotrophin deficiency is a clinical state characterized by a reversible suppression of the hypothalamic-pituitary-gonadal axis. Unlike congenital forms, such as Kallmann syndrome, it is acquired and results from physiological or environmental stressors, such as chronic systemic illness, psychological stress, anorexia nervosa, excessive physical exercise, hyperprolactinemia, etc. Kallmann syndrome leads to gonadotropin deficiency through a specific developmental failure, the failure of GnRH-secreting neurons to migrate to their correct location in the hypothalamus during embryonic development. Hypergonadotropic hypogonadism may be due to acquired gonadal damage or congenital gonadal disorders. Acquired gonadal damage may be due to chemotherapy or radiotherapy to gonads, trauma or surgery to gonads, autoimmune gonadal failure, mumps or orchitis, tuberculosis, or hemochromatosis. Congenital gonadal disorders include steroid biosynthetic defects, anorchidism or cryptorchidism in males, Klinefelter syndrome, and Turner syndrome. Confirmation of hypogonadism is done by measuring testosterone in boys and estradiol in girls. Distinction between hypo and hypergonadotropic hypogonadism is done by measuring random LH and FSH. If they are low, then the differential diagnosis lies between constitutional delay and hypogonadotropic hypogonadism. If they are high, then the diagnosis should be hypergonadotropic hypogonadism. If hypogonadotropic hypogonadism is suspected, investigation for pituitary disease is needed. If hypergonadotropic hypogonadism is suspected, chromosome analysis should be performed. Bone age assessment. A plain X-ray of the hand and wrist compared to standard films can be used to determine bone age. Laboratory tests should include a full blood count, assessments of renal, liver, and thyroid function, and screening for celiac disease autoantibodies. Management. Induction of puberty can be achieved by low doses of oral estrogen in girls, and testosterone gel or depot testosterone esters in boys. Duration of therapy. In case of constitutional delay, treatment is continued until puberty. If there is any underlying cause, then until reversal of the cause. If hypogonadism is permanent, lifelong treatment is required. Thanks for watching this video. Please like, share, comment, and subscribe to this channel.